The Recovery Kernel. Substance-Specific Navigation Series. How to recover from nicotine. Using the Recovery Kernel Framework. Cigarettes, vaping/e-cigarettes, nicotine pouches, snus, chewing tobacco, hookah, cigars, pipes. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. Nicotine is the most globally prevalent addiction. The medicine exists. The biology is understood. Quitting is possible for every person who wants to, with the right support. A note before you begin. 1.3 billion people smoke tobacco worldwide. More people are addicted to nicotine than to every other substance in this guide series combined. Tobacco kills approximately 8 million people annually, more than alcohol, opioids, stimulants, and every other recreational drug added together. And nicotine addiction is one of the most successfully treated substance use disorders in medicine, with multiple evidence-based pharmacological options, clear genomic predictors of response, and cessation rates that improve dramatically with the right combination of tools. The gap between the scale of the problem and the sophistication of the treatment conversation is extraordinary. People who would never consider treating opioid withdrawal without buprenorphine will attempt nicotine withdrawal with willpower alone, and fail, repeatedly, concluding that they cannot quit rather than that they are using inadequate tools. The compendium's GLP-1 section names tobacco and nicotine directly, multiple anecdotal reports of spontaneous smoking cessation or reduction, clinical trials ongoing as of 2026. The same mechanism that dampens the reward-wanting signal for alcohol and opioids is producing spontaneous cessation in nicotine-dependent people on semaglutide. Nicotine addiction is a neurobiology problem with pharmaceutical solutions. The same framework that applies to every other substance in this series applies here, with an even richer evidence base. This guide covers every delivery form: cigarettes, vaping, nicotine pouches, snus, chewing tobacco, hookah, because the nicotine is the addiction regardless of the delivery mechanism, and the delivery mechanism determines the specific physical health risks being accumulated alongside the nicotine dependence. The genomics are clear. The medications are available and effective. The biology of recovery is understood. What this guide provides is the complete framework for using all of it. Section 1: What nicotine did to your brain. Classical: building the Centurion, the most efficient dopamine delivery system available over any pharmacy counter. Nicotine reaches the brain within 10 seconds of inhaling a cigarette. This speed of delivery is faster than intravenous cocaine and comparable only to smoked crack in the speed of its CNS impact. The addiction mechanism is clear and well documented. Nicotine activates nicotinic acetylcholine receptors, NACRs, in the ventral tegmental area, VTA, producing dopamine release in the nucleus accumbens. The most important nicotinic receptor subtype for addiction, the alpha-4-beta-2 NACHR. Nicotine's activation of this receptor is the primary driver of the dopamine release that produces cigarettes' rewarding properties. Chronic nicotine exposure downregulates alpha-4-beta-2 receptors, and then withdrawal deprives those receptors of the nicotine signal they have come to require, producing the withdrawal state. 1.1 The multi-system impact of tobacco. 1.2 The tobacco product landscape. 1.3 The psychiatric comorbidity pattern. Classical: building the Centurion. Smoking is not random, it concentrates in the most neurobiologically vulnerable populations. The compendium's framework of substance use as a signal pointing to underlying biology is nowhere more clearly demonstrated than in tobacco. Smoking rates in the general population, approximately 12 to 15% in developed countries. Smoking rates in psychiatric populations. Schizophrenia and schizoaffective disorder, 70 to 90%. People with schizophrenia are using nicotine's NACHR agonism to modulate the hypodopaminergic state that the illness and its antipsychotic treatment produce. They are self-medicating with a degree of biological precision that the recovery framework must acknowledge. Bipolar disorder, 40 to 70%. Nicotine's mood-stabilizing effects, through NACHR-mediated serotonin and dopamine modulation, serve a genuine mood regulation function that cessation removes. ADHD, 35 to 40%. Nicotine's cognitive sharpening effects through NACHR activation in the prefrontal cortex directly address ADHD's dopaminergic deficit. Nicotine is ADHD self-medication. Major depressive disorder, 40 to 60%. The MAO inhibitors in tobacco smoke provide genuine antidepressant effects that pure nicotine does not replicate, making tobacco cessation harder than nicotine cessation for people with depression. Alcohol use disorder, 70 to 80%. The stimulant-depressant interaction, shared dopamine circuitry, and social co-conditioning produce the highest smoking alcohol co-occurrence in addiction medicine. This pattern means, for many people, tobacco cessation requires simultaneous management of the psychiatric condition that tobacco was serving. Cessation without psychiatric support in these populations routinely fails, not because of insufficient willpower but because a genuine therapeutic function has been removed without replacement. Section 2, Your Genomic Blueprint. Nicotine addiction has one of the most thoroughly characterized pharmacogenomic profiles in all of addiction medicine. The ChRNA5/ChRNA3/ChRNB4 gene cluster is the strongest genetic predictor of nicotine dependence identified in genome-wide association studies. CYP2A6 determines how fast nicotine is cleared, with direct implications for MAT selection and dosing. The DNA testing panel for nicotine recovery. Phenotyping without testing. Did you smoke more than a pack a day and find it significantly harder to quit than peers? Likely ChRNA5RS1696998A allele. Varenicline is your best MAT option. Do you smoke fewer cigarettes but find each one feels very satisfying and necessary? Possible CYP2A6 slow metabolizer. NRT patch, steady delivery, may suit you better than gum. Did you start smoking for the focus benefit and do you also struggle with attention? DAT1/DRD4 ADHD profile. ADHD evaluation alongside cessation planning. Did smoking reliably reduce your anxiety and do you find cessation produces severe anxiety? SLC6A4 short/short. Anxiety management is co-primary in your cessation plan. Did smoking help with depression and do previous quit attempts produce severe depressive episodes? MTHFR plus tobacco MAO inhibitor dependence. 5-MTHF first, bupropion as cessation aid, psychiatric monitoring during cessation. Section 3, Medication-Assisted Treatment, the most effective cessation tools. Classical building the Centurion, combination NRT plus varenicline is now the most effective single intervention for nicotine cessation, more effective than any willpower-based approach. The evidence base for nicotine cessation pharmacotherapy is more robust than for almost any other substance use disorder. Multiple large clinical trials across decades have produced clear, actionable guidance. The person who attempts nicotine cessation without medication support is statistically likely to fail, not because they lack commitment but because they are attempting an unnecessarily difficult neurobiological task without available pharmaceutical assistance. 3.1, The medication options. 3.2, The cessation strategy framework. Classical building the Centurion, medication is the foundation, not the entire structure. The most evidence-based cessation approach combines 1. Pharmacological support from the medications above, 2. Behavioral support through cessation counseling or a structured program, and 3. The biological recovery support in Section 4. Each component addresses a different dimension of the addiction. Pharmacological, reduces withdrawal severity and reward from smoking, making cessation neurochemically more manageable. Behavioral, identifies triggers, builds coping strategies, addresses the ritual and habitual dimensions of smoking behavior, the coffee-cigarette pairing, the post-meal cigarette, the stress cigarette reflex. Biological recovery, rebuilds the dopamine, serotonin, and NACHR systems that nicotine has adapted, providing the neurochemical substrate for genuine comfort in cessation. The quit date approach, set a specific quit date 1 to 2 weeks in advance. Begin varenicline or bupropion 1 week before the quit date. The medication needs time to reach effective plasma levels. NRT begins on the quit date. Having the medication already at therapeutic levels on the quit date dramatically improves outcomes. The gradual reduction approach, for people who cannot commit to a quit date, structured reduction over 12 weeks with NRT as a bridge, reducing cigarette count by 50% in the first 4 weeks, 75% by week 8, quit by week 12. Less studied than the quit date approach but may improve engagement. The dual use period, using NRT or varenicline while still smoking is not failure, it is a harm reduction phase for people in the approach stage. Combination NRT during a pre-quit period is associated with higher ultimate cessation rates. Section 4, Biological Reconstruction. Nicotine cessation produces withdrawal symptoms that are genuinely biological, not character weakness. The NACHR upregulation that chronic nicotine produced means the receptors are now undersupported by their endogenous ligand, acetylcholine. The MAO inhibitors that tobacco smoke contained are gone. The dopamine release that each cigarette produced is absent. The biological reconstruction protocol supports the recovery of all 3 systems. 4.1 The Methylation Foundation. 5-MTHF, 400 to 1000 micrograms, morning serotonin and dopamine synthesis support. For MTHFR variant smokers who were managing depression through tobacco's MAO inhibitors, 5-MTHF provides the synthesis support that can partially replace the mood-stabilizing function. Methylcobalamin, 1000 to 2000 micrograms sublingual, morning methylation support, particularly relevant for smokers who have been consuming nicotine-associated oxidants that deplete B12. P5P, 25 to 50 mg, morning cofactor for monoamine synthesis pathways that tobacco's MAO inhibitors were enhancing. Magnesium glycinate, 400 to 600 mg elemental, evening anxiety reduction, GABA support, sleep improvement, all 3 major withdrawal symptom domains addressed. 4.2, NACHR system restoration. Classical building the centurion, supporting the receptor system that was calibrated around nicotine. The nicotinic acetylcholine receptor system needs time to downregulate back toward its pre-smoking density and sensitivity. This process takes 4 to 6 weeks for the NACHR population to substantially recover. The following supports this recovery. Alpha-GPC, 300 to 600 mg, morning choline precursor for acetylcholine synthesis. As the nicotinic receptor system readjusts to relying on endogenous acetylcholine rather than exogenous nicotine, supporting acetylcholine synthesis helps maintain the cognitive and mood functions that nicotine was enhancing. CDP choline, citicoline, 250 to 500 mg, morning combined choline and cytidine source. Supports both acetylcholine synthesis and dopamine receptor recovery, addressing the NACHR and dopamine dimensions of nicotine withdrawal simultaneously. Lion's mane mushroom, 500 to 1000 mg, daily NGF and BDNF stimulation. Nicotine has documented neuroprotective effects through NACHR activation of neurotrophic factors. Lion's mane provides NGF stimulation through a different pathway, partially replacing this neuroprotective function. Huperzine A, 50 to 100 micrograms, daily, cycle with breaks acetylcholinesterase inhibitor, slowing acetylcholine breakdown. Supports cognitive function during the period when acetylcholine activity is reduced by the absence of nicotinic potentiation. Use on alternating weeks to prevent tolerance. 4.3, Dopamine and mood recovery. L-tyrosine, 500 to 1000 mg, morning, away from protein dopamine precursor. The dopamine contribution of nicotine's NACHR activation is significant. Tyrosine supports the dopamine system as it re-establishes independent function. NAC, 600 to 1200 mg, daily, divided glutamate homeostasis and craving reduction. Evidence in cigarette cessation specifically. Begin immediately on cessation. Rhodiola rosea, 300 mg, morning dopamine and serotonin modulation, adaptogen, anti-fatigue. The motivation and energy deficit of early nicotine cessation responds to rhodiola's gentle dopaminergic support. 5-HTP, 50 to 100 mg, evening serotonin reconstruction for the mood and anxiety component. The tobacco MAO inhibitors were providing genuine antidepressant effects. 5-HTP supports serotonin recovery as that mechanism is removed. Do not combine with SSRIs. 4.4. The weight gain management. Classical building the centurion, 4 to 8 pounds is expected, metabolically normal, and not a permanent state. Nicotine suppresses appetite through hypothalamic POMC neuron activation and increases metabolic rate slightly. Cessation removes both effects. Weight gain of 4 to 8 pounds on average is the biological consequence. This weight gain is not related to eating more, it occurs even with controlled caloric intake. It is the metabolism normalizing from nicotine-enhanced levels. The weight gain is most pronounced in the first 3 months and stabilizes or reverses with exercise and time. Do not use weight gain anxiety as a reason to continue smoking. The cardiovascular and cancer risk of smoking far exceeds the health risk of 4 to 8 pounds. Exercise, particularly the aerobic exercise in Section 5, is the most effective weight management tool during nicotine cessation and provides the dopamine and endorphin replacement that supports cessation simultaneously. GLP-1 agonists, semaglutide, tirzepatide for people where weight gain concerns are a significant cessation barrier. GLP-1 agonists address both, the cessation support mechanism and the weight management concerns simultaneously. Discuss with prescriber. 4.5. Sleep reconstruction. Nicotine disrupts sleep through NACHR-mediated arousal, yet paradoxically many smokers report that cigarettes help them sleep. This reflects the withdrawal anxiety that a cigarette resolves before bed. The cigarette is managing nicotine withdrawal rather than producing sleep. Cessation initially produces vivid dreams, NACHR recovery producing REM rebound, and sleep fragmentation that resolves within 2 to 4 weeks. Melatonin, 0.5 to 1 mg sublingual, consistent time circadian support during the initial sleep disruption. Magnesium glycinate, 400 mg evening the primary tool for cessation-related anxiety that prevents sleep onset. Glycin, 3,5-G, 30 minutes before bed core body temperature reduction for sleep onset. L-theanine, 200 mg evening alpha wave promotion, reduces the cognitive hyperactivity of nicotine withdrawal. Varenicline's vivid dream side effect is NACHR-mediated sleep architecture change. It is not dangerous, resolves with time, and for most people is manageable. If severe, taking varenicline earlier in the day, not with evening meal, reduces the sleep impact. 4.6. Pulmonary recovery. Within 20 minutes, blood pressure and heart rate normalize. Within 12 hours, carbon monoxide cleared from blood, oxygen carrying capacity normalized. Within 2 weeks, circulation improving, lung function improving measurably. Within 1 year, cardiovascular disease risk halved. Within 5 years, stroke risk comparable to non-smoker. Within 10 years, lung cancer risk halved. N-acetylcysteine, NAC 600 mg twice daily mucolytic, helps clear the accumulated mucus and reduces oxidative stress from decades of smoke exposure. Particularly valuable in the first months of cessation. The compendium names NAC and glutathione as specifically depleted by cigarettes/alcohol. Replenishment is a genuine recovery support. Vitamin C, 1,000 to 2,000 mg daily cigarette smoke dramatically depletes vitamin C. Smokers require significantly higher vitamin C intake than non-smokers even after cessation as the antioxidant capacity rebuilds. Vitamin E, 400 IU, mixed tocopherols fat-soluble antioxidant for pulmonary membrane repair. EGCG, green tea extract, 400 mg antioxidant with specific pulmonary tissue protective properties, reduces the oxidative stress from tobacco smoke residue. Section 5. The nicotine craving, understanding and interrupting. Classical building the centurion, the 3-minute craving, and the architecture that makes it manageable. Nicotine cravings have a specific and documented temporal profile. The peak intensity of a nicotine craving lasts 3 to 5 minutes. Not 30 minutes. Not an hour. 3 to 5 minutes. Every nicotine craving in the first 2 to 4 weeks of cessation will peak and subside within 5 minutes if it is not acted upon. This is the most clinically useful single piece of information in nicotine cessation. The craving feels like it will go on forever. It will not. It will peak in under 3 minutes and then decline. The entire intervention has to do is outlast 3 minutes. The nicotine craving trigger map. The nicotine craving interrupt, 3-minute protocol. Set a 3-minute timer. Name the craving and set a timer. The craving will be gone or substantially diminished when the timer ends. This is not a metaphor, it is the documented temporal profile of a nicotine craving. Execute 4-7-8 breathing, 5 cycles. The anxiolytic function of nicotine is partly the parasympathetic activation of the smoking breath itself, the long exhale of blowing smoke. 4-7-8 extended exhale provides the same vagal activation without the nicotine. Use NRT rescue. Nicotine gum or lozenge provides rapid, 10 to 15 minute, nicotine delivery that arrests the withdrawal craving. NRT is not failure, it is the medication working as intended. Use it. Hydrate. Drink 16 ounces of water immediately. Dehydration compounds withdrawal irritability and the bodily discomfort of nicotine deprivation. Change physical location. Move away from the triggering environment. Walk outside. The craving's contextual component is disrupted by physical environment change. Wait. The timer is expiring. The craving has peaked. It is declining. Section 6, Building the Natural Architecture for What Nicotine Provided. Classical building the centurion, the 4 functions cigarettes were serving, rebuilt without the carcinogens. Every cigarette was serving multiple functions simultaneously: dopamine reward, anxiety management, cognitive sharpening, social belonging, stress ritual. The natural recovery architecture addresses each. The functional replacement map. Section 7, Navigating the Recovery Kernel, your protocol map. Section 8, The medical context. 8.1, Medical monitoring in nicotine recovery. Pulmonary function, spirometry if COPD or significant respiratory symptoms. Baseline establishes the improvement trajectory that is motivating for continued cessation. Cardiovascular, blood pressure, lipid panel, echocardiogram if indicated. Cardiovascular improvement from cessation is rapid and measurable. Oral health, dental evaluation. Tobacco causes significant gum disease, tooth staining, and oral tissue changes. Cancer screening, lung cancer CT screening is recommended for heavy smokers, 20+ pack years, aged 50 to 80. Discuss with primary care. Thyroid, tobacco's cyanide exposure affects thyroid function. Thyroid assessment for anyone with symptoms. 8.2, Resources. Smokefree.gov, free cessation support including text message coaching, text quit to 47848, live chat, and app. 1-800-QUIT-NOW, free state cessation quit line available in all 50 states, counseling and NRT may be provided free. Prescriber, any primary care provider can prescribe varenicline and bupropion. Ask specifically. Nicotine Anonymous, nicotineanonymous.org, peer support community for nicotine cessation. Alan Carr's EasyWay, the most evidence-supported bibliotherapy approach for nicotine cessation. A final word. Classical building the centurion, the most common human addiction has the best available treatment. Use it. 8 million people died from tobacco in 2022. 1.3 billion people are currently dependent on nicotine. The medicines that help people stop exist, are available, are covered by most insurance, and are more effective than almost any treatment for any other chronic condition in medicine. And the majority of people who want to quit attempt it without medication, without varenicline, without NRT, without bupropion, and fail, and conclude that they cannot quit. They cannot quit using willpower alone. The neurobiology of nicotine dependence is real and significant. It is not a character failing that the dopamine system adapted to 20 cigarettes a day. It is not a character failing that the NACHR population upregulated around chronic nicotine exposure. These are predictable biological adaptations to a powerfully addictive molecule delivered by the fastest available CNS delivery mechanism. The recovery framework is clear. The medicine is available. The genomics are understood. CHRNA5A allele carriers respond best to varenicline. CYP2A6 slow metabolizers get more nicotine per cigarette and somewhat easier cessation. MTHFR variant carriers need 5-MTHF and targeted mood support during cessation. SLC6A4 short carriers need anxiety management built into the cessation plan. The precision is available. And the natural recovery architecture, the exercise that replaces nicotine's dopamine, the breath work that replaces the anxiolytic cigarette, the choline support that replaces the NACHR cognitive enhancement, is equally available. 8 million people per year. The medicine exists. The biology is understood. This guide was built so that number can be smaller. Smokefree.gov 1-800-QUIT-NOW Nicotine Anonymous, nicotineanonymous.org. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. How to recover from nicotine using the Recovery Kernel Substance-Specific Navigation Series.